would like to welcome Dr. Mishka Turplin, Deputy Chief Clinical Officer at the Department of Behavioral Health, who will introduce the next session. Dr. Turplin, welcome.
Great. Well, thank you. And thank you. It's a pleasure to be here to introduce this next session. This is a session that's going to focus on the impact of social determinants of health on the opioid and substance use disorder population, and the use of alternatives to opioids for pain management for individuals with opioid and substance use disorders and chronic pain. Dr. Gregory Kahn Arthur and Dr. Palak Turakia will discuss their experiences as clinicians in this space, offer guidance on best practices, and discuss the future of opioid addiction treatment and pain management from the clinical perspective. Dr. Gregory Kahn Arthur joined the Mid-Atlantic Permanente Group in 2018. He's board certified in pain medicine and addiction medicine and a specialist for Kaiser Permanente's comprehensive pain management program. He's also the regional physician lead for opioid management and pain programming, while also serving as the chief of pain management in the Baltimore service area. He's a native of Brooklyn, New York, and graduated Vassar College, where he studied biology with minor concentrations in neurophysiology and education prior to attending medical school at the University of Medicine and Dentistry of New Jersey in Stratford. Dr. Palak Turakia is board certified specialist in anesthesiology and pain medicine and serves as co-division chief in pain medicine at the George Washington University Hospital, where she has given multiple grand rounds to the departments of medicine, obstetrics, gynecology, and anesthesiology, and is a member of the Medical Faculty Associates Opioid Prescribing Task Force. She completed both her medical degree and master's in public health at Tulane University, where she was president of the medical student government and helped facilitate the temporary transition of the medical school to Houston during Hurricane Katrina. I will turn it over now to Dr. Kahn Arthur to begin. Thank you.
Hello, everyone. Hopefully you can hear me well. Thank you very much for having me. Again, I'm Dr. Kahn Arthur from the Mid-Atlantic Permanente Medical Group, and I'll be talking today about alternatives to opioids in pain management. And so you know, I have my main practice is in the outpatient realm, so I'm going to try to focus on that realm and also in the areas of transitioning from, say, inpatient management to outpatient management and that approach, but also keeping in mind some considerations where it comes to addiction and other special cases. Next slide, please. So our objectives today are going to be to explain the use of multimodal analgesia in pain management. The concept of multimodal analgesia is important to have under our belts when we're considering how to approach the treatment of chronic pain, especially. We will also describe some opioid sparing approaches in pain management, and I'll give you some examples that will kind of demonstrate multimodal analgesia in practice for specific disease states. And I will also discuss some important considerations in pain management, as I mentioned, for patients with opioid use disorder. Next slide, please. So our understanding of pain, and certainly chronic pain, has come a very long way since many, many years ago. This diagram here of the person with their foot in their fire comes from the old Cartesian concept of pain as kind of a one-way pathway where a noxious stimuli, depicted as fire in this case, it travels up a nerve of some sort and gets through the spinal cord up to the brain, where we become aware of the pain. This very one-way kind of mechanistic conceptualization of pain, of course, has been very greatly expanded over the years. And now we're at a point, a very exciting time in history, especially in the study of pain, where we understand pain to not only be the result of a noxious stimuli and physical sensations, but also of higher levels of cognition, memory, emotions, that sort of thing. So we have a very nuanced understanding these days. And some of the depictions on the right here depict things like central sensitization and how many different parts of our central nervous system interact and interplay with one another to help us to not only detect noxious stimuli, but also interpret them and then help us to react to them. At the junction of our peripheral nerves with our central nervous system, there's a whole milieu of chemistry and assortment of receptors that we know play an integral part in pain perception and transmission. And that in and of itself is a very not difficult, but complex situation happening there at the dorsal horn. And then in the periphery, where the injury usually is first detected, there's also a host of chemical mediators and inflammatory cytokines and things like that that also help to initiate nervous signals. So it's a far more complex system, to say the least, than our initial understanding many, many years ago. Next slide, please. So in order to truly address pain, especially chronic pain, it's important to have that understanding of pain as a very complex system of detection, transmission, integration, perception, that each has its own specific mechanisms, chemicals, transmitters, receptors that are necessary in order for each part of that system to work. So the concept of multimodal analgesia really is designed to take advantage of this complex system by addressing different parts of the pain signaling, processing, integration pathways in order to reduce pain and reduce quote unquote pain signals as they travel and bounce around our nervous systems. The concept was first elaborately described by Sergei Motov, who's Dr. Motov was I believe he was an emergency room physician at Maimonides Medical Center, which also happened to be where I did my residency. And what he described there was a system of what they call SERTA, channels, enzymes, receptors, and targeted analgesia. And using these different mechanisms and these different underpinnings of these mechanisms, we can utilize different medications, different practices, different procedures to target these different mechanisms in order to reduce pain. And it's a very patient-centered approach in that it uses a combination of treatments, and anytime you offer patients greater choice and can discuss with them the many different underpinnings of their pain, the more invested they are usually become and are capable of participating more fully in their care. And again, it's a mechanistic framework. It's there to target physiologic pathways. And it's also evidence-based, by the way. It's also based in a lot of good research and many ways of approaching pain. For example, alternatives to opioids programs in emergency departments across the country, otherwise known as ALTO protocols and programs, have been developed under the umbrella of multimodal analgesia, as well as what we may be familiar now as ERAS, or Enhanced Recovery After Surgery, does certainly have a multimodal analgesia component to it. Next slide, please. So this eye chart here, sorry if you can't read this, I know that the type is very small, kind of lists on the left here the SERTA class. So just going down, there are many different underlying mechanisms here, including COX-1, COX-2 inhibitors for the anti-inflammatories. Other examples commonly are sodium channel blockers, which we usually leverage things like lidocaine and bupivacaine against, that sort of thing. Our dopamine receptors, which we can leverage things like metoclopramide and even Haldol and that sort of thing against. NMDA is a very new and burgeoning kind of area for pain management. And so when you hear about people using ketamine infusions and even in ERs using things like nitrous oxide to help manage pain, it's those NMDA glutamate receptor antagonism mechanisms that they're targeting there. GABA receptors, of course, propofol is probably the gold standard of that. We all know that that works really well, and our anesthesia colleagues can attest to that. Serotonin receptors with things like sumatriptan, calcium channel blockers like gabapentin and pregabalin used very frequently in chronic pain management, and on and on. And of course, I'd be remiss if I didn't mention the opioid receptors. Not only the mu receptors as listed in this table, like our prototypical morphine and oxycodone and hydrocodone and things like that, but also the interplay of other opioid receptors, such as the kappa receptor, that drugs such as buprenorphine tends to take advantage of, that can also help to affect the affective or the emotional aspects of pain, help to reduce depression and anxiety, while also reducing noxious stimuli being transmitted through the spinal cord pathways. And then, the colored boxes here are just colored in based on the kinds of pain diagnoses that we typically use these very different mechanisms to address. So, on the top there, we have everything from musculoskeletal pain, arthritis, dysmenorrhea, gout, neuropathic pain of all kinds, migraine, gastroparesis, that sort of thing. So I find this to be a very helpful chart sometimes if I just need to jog my memory on what classes of medications can I leverage against a particular clinical situation. Next slide, please. So one of the classes that I definitely wanted to highlight includes the NSAIDs. These are probably one of the most underutilized, and sometimes for good reason, because sometimes it's dangerous to use NSAIDs, especially chronically. However, they are especially useful, especially in early injury, like immediately after tissue damage or tissue injury, in the close post-operative period, once there's less concern about bleeding and things like that, using or transitioning from a short course of opioid therapy after surgery to using NSAIDs, like for example in joint replacements, is often a very good idea because it will address pain in an effective way while also reducing inflammation along the way, especially during a rehab course, for example. Controlled substances often have this perception about them where people have the false notion that they are more effective than all of the other pain management modalities. But as you can see here from our dental colleagues who have studied this intensively and highlighted the work here of Dion and Bertold, that doses of ibuprofen can be just as effective as doses of oxycodone when compared head to head. And same thing is true on the right that you can see here for comparing doses of morphine to dosing ketorolac. When blinded, patients often achieve the same amount of pain reduction when graded on an analog scale, or I think they use the visual scale here when comparing to, say, opioids. So NSAIDs can be very effective. It's just a matter of giving them a good try. Now, of course, we do have to take into consideration that they can affect the kidneys. You do have to be very careful with patients with chronic renal insufficiency, and certainly with anybody with a history of GI bleeds, or if they're prone to GI bleed. Next slide, please. Another one that I will also include in the anti-inflammatory realm, although it's much more than that, is acetaminophen. It's often described in the research literature as a COX-3 inhibitor, which I think has only officially been described in canines, but they do posit that it may also be true in humans as well. But it does so much more than that. It also has metabolites which act very much like medical cannabis, to put it mildly. It does inhibit sodium channels to prevent reuptake of endogenous cannabinoids, so thereby increasing the availability of our endogenous cannabinoids within our system. And we believe that is a part of how it actually affects pain. So I kind of jokingly do tell my patients that I do highly recommend acetaminophen, especially if they have sensitivities or contraindications to NSAIDs. And I kind of jokingly say it's kind of like using medicinal cannabis, because it does kind of increase the availability in your body to its own cannabinoids, which can, current research is showing, can certainly help with pain. Which kinds of pain and whether or not they would be indicated for these kinds of pain in the future is remains to be seen, but acetaminophen nonetheless still is an effective pain management strategy, and as you can see here, is much more effective than placebo and on par with some other of our more potent NSAIDs. Next slide, please. So getting into examples of multimodal analgesia here, these are some examples that I borrowed from St. Joseph Regional Medical Center, where they use an alternatives to opioids program in their ER. So for example, I've listed 3 clinical situations here where they have acute or on chronic radicular low back pain, extremity fracture, joint dislocation, and renal colic. For the acute on chronic radicular low back pain, you'll see that they have a combination of different medications that they use kind of as a cocktail or as an approach to address the different mechanisms associated with that particular kind of neuropathic pain. And that's a combination of acetaminophen, an NSAID, a muscle relaxant, gabapentin as a stat dose, by the way, not chronically, even steroids, lidoderm patches, and interestingly, ketamine. Ketamine is gaining a lot more standing these days, especially in the ER community and in the chronic pain realm for neuropathic pain in general. And it's proven to be, fairly safe. We've used it for procedural analgesia and anxiolysis for a very long time. And of course, procedures such as trigger point injection, dry needling, acupuncture, that sort of thing. Extremity fracture, again, you see ketamine there as an intranasal dose rather than IV. Nitrous oxide, which requires a proprietary kind of delivery system to ensure that the mixture is not above 70%, but can also be very effective. And also you see here the combination with acetaminophen and more procedures, such as, of course, a reduction for a joint dislocation, and even ultrasound-guided regional anesthesia, which used to be the domain of anesthesiologists for a long time, but there are many different courses available for ER docs, internists, and others to take to become more proficient at peripheral nerve blocks or even deeper trigger point injections and that sort of thing. And of course, renal colic here, the tried and true ketorolac, lidocaine infusions. The evidence is still being developed for this, but if you're familiar with ERAS protocols, intravenous lidocaine has been shown to be effective in postoperative pain, and has also been used in renal colic, and is currently being studied for that as well. Next slide, please. So a little bit more in procedural delivery of multimodal analgesia. We've already been using them for a very long time. How much of it can be done at the bedside is kind of limited, although there's more and more available all the time, especially in the field especially in combination with something like point of care ultrasound and that sort of stuff. It's been able to help us to bring these procedures more easily to the bedside. But for inpatients, certainly, rather than treating pancreatitis pain, for example, with tons and tons of opioids, consulting a good endoscopist who can do a celiac block could help you spare a lot of opioids. And sometimes ablating using alcohol or other methods during that celiac block can give you longer lasting pain relief than many of the opiates that we classically use. But there are many other examples of procedural analgesia. It's just another way of delivering multimodal analgesia to the point that makes it most effective. And of course, it doesn't always require medications. You can also do manual manipulation, such as in the osteopathic world or chiropractic world. Sometimes these manipulations, there are procedures, can help relieve muscle tightness, muscle tension, improve range of motion, which ultimately helps the painful condition. Even if it just takes a couple points off of the pain scale or helps to improve function a little, it is nonetheless worthwhile to include in the multimodal approach. Next slide, please. So for considerations in substance use disorder, one thing that I always try to mention in this realm is that, when we encounter patients who have had problems with substance use disorder, especially opioid use disorder, they may be on things to help them to sustain remission. And often there's a hesitancy, especially when patients are admitted to the hospital, to aggressively treat their pain because we're afraid of, messing up the medication-assisted therapy or overdosing the patient accidentally, or we're not even certain whether we're allowed to combine classical full agonist opioids with things like methadone or buprenorphine and that sort of thing. So one thing I want to make sure I say is that, daily dosed methadone from methadone treatment facilities does not usually confer analgesia beyond the first 6 to 8 hours, and usually it's even shorter than that. Oftentimes in patients who I have that are receiving methadone from a methadone treatment facility, if we wanted to use that methadone for the added benefit of analgesia, we often work together with the methadone treatment facility to increase frequency to every 12 or every 8 hours. But of course, never use methadone PRN. We don't advocate for that in chronic pain management or in addiction management. But it is something that can be helpful in helping to cover pain and to also address the underlying need to keep that patient in remission from an opioid use disorder. Studies have shown that relapse risk is much higher when there's inadequate pain management, especially during acute chronic pain, like after surgery or after injury. So even patients who are on methadone, they can still receive breakthrough pain medication or an acute course of opioid analgesic if the clinical condition warrants it. So there should be no hesitancy to utilize additional immediate release opioids in addition to the patient receiving their regular daily dose of methadone or buprenorphine for that matter as well. So that is certainly something to keep in mind, that the rules of multimodal analgesia can still be leveraged in patients who are receiving these maintenance therapies. Next slide, please. So again, I mentioned patients on buprenorphine. I mean, this is huge right now. We've gotten some recent changes to the X waiver, or the Data 2000 waiver for the prescription of buprenorphine. Many more providers are going to be prescribing this medication for opioid use disorders in the outpatient setting. So we may be seeing more and more of it in the inpatient setting as well. Again, it's a mu receptor agonist with very high affinity. It is a very effective pain medication. It comes in many different forms. We've done surgeries and performed things like hysterectomies and things like that in patients who have been treated with nothing more than buprenorphine. So it is a very effective medication. The two that are indicated for pain, I'll talk about in a little bit, but the ones that you have to keep an eye out for are the ones that are indicated only for opioid use disorder, which include the buprenorphine with naloxone products like Suboxone and sublingual buprenorphine in the form of Subutex, or even the new implant Sublocade. It's not really new, but it's newish to some healthcare systems. So clinical considerations, if you're treating a patient with buprenorphine that's taking it for a substance use disorder, is to consider splitting the dose. Work with that addiction specialist to split the dose to every 8 hours to better cover pain while also addressing the opioid use disorder maintenance. Next slide, please. And then, of course, buprenorphine for pain is a legitimate labeled use. Some things to keep in mind is there is no ceiling effect for analgesia on buprenorphine. The higher you go with buprenorphine, typically the more pain reduction you achieve. However, there is a theoretical plateau for respiratory depression. That may be true depending on the patient. Certainly comorbidities and age and things like that come into play, but there's a theoretical plateau for respiratory depression. So that is to say, there comes a dose where if you go any higher, it's not going to depress respiratory rate or tidal volume further. It is a mu receptor agonist with very high affinity. It also has antagonism at the kappa receptor, which has good mood effects. It can help reduce anxiety and depression when used chronically. Has a very favorable safety profile. I use it in practice in the butrans form or buprenorphine transdermal form to treat patients with renal insufficiency that have chronic pain, and also my more frail elderly patients who require a sustained release opioid of some kind. There's also buccal buprenorphine, which comes in the form of Belbuca. And for inpatient use only, there is also IV buprenorphine in the form of Buprenex. So that's buprenorphine for pain. Next slide, please. Very important consideration in patients with especially things like alcohol use disorder or even in opioid use disorder, if they're using naltrexone maintenance therapy. Usually addiction specialists that prescribe this will try our best to make sure they have a medic alert band or some kind of blaring notation in their record somewhere so that everybody knows that if a patient requires opioid analgesia for an emergent situation or for surgery or something like that, this has to be pre-planned. And certainly this is one of those times, if you see that they're on naltrexone maintenance therapy, you want to consult with an anesthesiologist because they will probably need a lot more support for their pain. And if you're trying to overcome the naltrexone with opioid analgesics, it's going to take much higher doses. So specialty consultation is certainly warranted in a case as this. Next slide, please. And these are just some references here. I'm not sure how I'm doing on time, but if we have time for any questions or comments, I'd be happy to take them. I hope you found some of this information useful, and thank you very much for having me.
Thanks, Dr. Khan-Arthur. We're actually going to save the Q&A until the end. We'll just turn it over to Dr. Tarakia.
Great, thank you.
Thank you.
Good afternoon. My name is Palak Tarakia. I am one of the division chiefs in the Division of Chronic Pain Medicine in the Department of Anesthesia here at George Washington University. And today I'm going to talk about multi-analgesia in the time of an epidemic. Next slide, please. So a little bit about myself. I am an anesthesiologist, but I'm also fellowship trained in chronic pain medicine. So I spend about 50% of my time in the operating room and then 50% of my time in the chronic pain clinic. Today, the focus of my talk will be focusing on patients in the perioperative setting, but much of what I talk about is easily translatable to the acute pain patient. And a lot of the medications I talk about, we use on the chronic pain service when we consult in the hospital and on the acute pain service for patients that we consult in the hospital. So we are in the middle of an opioid epidemic. You know, you can look at the graph from 2011 from 2000 to 2017, and you can see a sort of increase in opioid related deaths. I finished my fellowship in 2011. And it was right around the time that we started seeing a change in prescribing practices. And that was right around the time that, you know, physicians became a little bit more judicious in their use of prescription opioids. And you start seeing an increase in the overdose deaths from heroin. That has recently been supplanted by synthetic opioids. So right now, a lot of the overdose deaths are being caused by medications like fentanyl that are often laced in other controlled substances. Who would think that a pandemic is actually not great for the opioid epidemic? So, you know, if you look at the CDC numbers, there was a slight dip in the deaths in 2018, but when they look at the 12-month period between September of 2019 and August of 2020, they actually have predicted 88,000 deaths from opioid overdose. 26 states, including the District of Columbia, have shown an increase in your overdose deaths by about 30% in the last year. So again, this is still a very pertinent issue in our public health sphere. Next slide, please. So I like to show this slide because when you talk about prescription opioids among past non-medical users, it's interesting to see where these medications come from. So mostly in patients who are casual users, patients are often getting these medications from a friend or a relative for free. And this is actually from JAMA from 2014. But if you look at patients who are using opioids in a non-medical manner, between 200 and 365 days out of the year. So basically people who are using it non-medically almost every single day, most of them are actually receiving it as prescribed from a physician. Next slide, please. As an anesthesiologist, this isn't pertinent for us because the perioperative period may be the source of initial exposure for some patients. Persistent opioid use after major or minor surgery is approximately 6% and often becomes greater than 90 days. So we're definitely at a point where we can affect that. And then patients are often prescribed more than they need. About 40 to 70% of patients who are prescribed 40 to 70% of opioids prescribed postoperatively go unused. So at much higher risk for diversion. And for those of you who operate in surgical specialties, there's a great resource through the University of Michigan. It's called Michigan Open, and they have evidence-based recommendations for patients who are undergoing surgical procedures as to how many how many tablets of oxycodone or hydrocodone are recommended. Next slide, please. Other side effects of opioids includes postoperative nausea and vomiting, respiratory depression, constipation, ileus, urinary retention, and wound healing complications, delayed healing. So there are other reasons besides the epidemic that we want to try to minimize opioid use in the acute pain patient or in the perioperative setting. Next slide, please. Adjuvants that I will go into include non-steroidal anti-inflammatory drugs, acetaminophen, alpha-2 adrenergic agents, anticonvulsants, ketamine, and then intravenous lidocaine. Next slide, please. So non-steroidal anti-inflammatory drugs, the mechanism of action, you have an injury to your cell membrane, which causes a release of phospholipids, which are converted by phospholipase A to arachidonic acid, which is converted by COX-1 or COX-2 into prostaglandins, which are involved in central sensitization. It is the COX-1 and COX-2 that are inhibited by NSAIDs. NSAIDs, next slide please, may have side effects. There is concern of surgical bleeding, gastrointestinal bleeding, oliguria, and renal failure. So you want to be very judicious with who you prescribe these medications from. Next slide, please. But they are thought to be, they show a decrease in opioid usage and a decrease in opioid-related side effects, including nausea and vomiting. There aren't a ton of studies that show head-to-head comparisons, but in certain surgeries, preoperative celecoxib offers similar pain relief to ketorolac. My biggest piece of advice with the NSAIDs, if you're talking about using them in the perioperative setting, is to talk to your surgeon prior, to see what their comfort level is, because a lot of times, as healthcare providers, we are the sum of our own experiences. So certain surgeons have very strong opinions one way or the other about whether they would like NSAIDs to be part of their perioperative treatment. In the acute pain setting, so for patients who are not necessarily postoperative, I think they can also provide excellent relief. But again, you want to be judicious in your use in patients who don't have a history of cardiac disease, who may not be on other anticoagulants, and patients who have normal renal function. Next slide, please. So the next medication I'll talk about is acetaminophen. Acetaminophen is also a non-steroidal anti-inflammatory, although the exact mechanism of action is unknown. It's thought to enter the central nervous system and centrally inhibited prostaglandins via the COX pathway. It may reinforce the descending serotonergic inhibitory pathways, and it has weak peripheral anti-inflammatory activity and significant impact on platelet function. So for patients who can't use NSAIDs, I think, it works through a different mechanism. So it's definitely something to consider. Next slide, please. Acetaminophen has been shown to have opioid sparing effects in different types of moderate to major surgery. It's thought to help decrease postoperative nausea and vomiting, and it comes in 3 forms, which is really convenient as well. It comes in an oral form, a rectal form, and an intravenous form. One thing I find nice about acetaminophen is that it comes actually in a liquid form too. So in the chronic pain setting, I take care of several patients who have had a history of head and neck cancer. They have G-tubes, so it's difficult for them to take things by mouth. Not always a fan of, using the rectal form. So it comes in a liquid and it can be given to them via the G-tube. There's very little evidence supporting the intravenous form over the oral form in a perioperative setting. So we often, prior to surgery, give patients 1,000 milligrams of acetaminophen prior to them going back with a small sip of water. For patients who are having longer surgeries, some of our surgeries can last 12 hours, or for patients who are having something like a gastric bypass, those are the cases where we would consider using intravenous acetaminophen during the surgery. Next slide, please. NSAIDs and acetaminophen, it is thought that combining the 2 classes of drugs provide improved pain relief over either drug alone. And the most commonly studied NSAID in combination with acetaminophen has been ibuprofen. So when managing patients on these medications, I think it's important in the hospital or even, as an outpatient, to have them understand that they should take these medications as a scheduled regimen. I think that is going to be more efficacious in sort of decreasing opioid use than taking them PRN. Because if you have an acute pain flare, these aren't often the most immediate acting and strongest ways to get pain relief, but if they're taking it scheduled, it helps bring down the overall pain levels. So when we consult on patients in the hospital, whether it's in the acute pain service or the chronic pain service, we often make sure that these patients are scheduled with these medications. And if you are going to schedule them on these medications and they are on opioids in addition, something like Vicodin or Percocet, all of those formulations have Tylenol or acetaminophen in them. So you want to make sure that they are getting not over the maximum dose of acetaminophen. Next slide, please. So the next class of medications that I wanted to talk about were the alpha-2 agonists, medications like clonidine and dexmedetomidine. So it's thought that they have analgesic and sedative effects at the locus ceruleus and then the dorsal horn of the spinal cord. Next slide. So when comparing the two, when you look at clonidine, the analgesic effects are equivocal, and the use is limited by side effects including bradycardia and hypotension. Dexmedetomidine is a more selective alpha-2 agonist. It has a shorter duration of action than the clonidine, and it's been shown to decrease postoperative morphine consumption, postoperative nausea, vomiting, and the length of stay in certain populations. That being said, hot off the press in our anesthesiology journal, there was an attempt to try to use an opioid-free anesthetic in combination with patients getting dexmedetomidine, and the study actually had to be aborted rather quickly because several patients developed significant bradycardia. So definitely worth keeping an eye on. Clonidine itself is a useful adjunct intrathecally. So for patients who have cancer pain and end up with intrathecal pain pumps, we often do use clonidine to help with the neuropathic component of their pain. Next slide, please. The next group of medications that I'm going to talk about are the anticonvulsants, gabapentin and pregabalin. And I will say that when I'm in the chronic pain setting, I call myself the gabapentin fairy because I use it quite often. And I try to use that as first line over opioids for patients who have lumbar radiculopathy and neuropathy. They are similar medications. They both bind to the alpha-1 delta subunit of the presynaptic calcium channel. They both can help with anxiolysis. Gabapentin has saturable absorption, which makes it a little bit less easy to work with in the sense that it's zero order kinetics. At some point at a higher dose, 1,800 milligrams a day, 2,400 milligrams a day, your patients are only absorbing 50 to 60% of that medication, whereas pregabalin has dose-independent absorption. So the higher your dose, you're still absorbing a fair amount. So for patients who aren't getting benefit at the lower doses, and you want to try to do a higher dose, just be wary that sometimes with gabapentin, your absorption isn't going to change significantly. Next slide, please. So the mechanism of action, so voltage-gated calcium channels are upregulated in the spinal cord and the dorsal root ganglia after surgical trauma. So it's thought that they may produce anti-nociception by inhibiting the release of excitatory neurotransmitters. They reduce the excitability of dorsal horn neurons. The usage of them in the perioperative setting is, again, up for debate. In a recent study, it was shown that giving perioperative gabapentinoids patients did have better pain relief, did have a decrease in opioid requirements and adverse effects such as postoperative nausea, vomiting, and urinary retention. That being said, in a fairly recent article in one of my journals, it talked about, again, conflicting results with gabapentin. There was a decrease in pain scores at 6 hours, at 24 hours, and at 48 hours postoperatively, but not at 72 hours or 3 days. And it did show a decrease in your postoperative nausea and vomiting. That being said, the decrease in pain scores was not statistically significant. And along with this, patients had an increase in visual disturbances and dizziness, and an increase in your hospital stay. That being said, there are several surgeons that I work with who still like gabapentin prior to surgery. And when we are consulting on patients in the acute pain setting, or in the chronic pain setting for patients who are hospitalized with chronic back pain or, neuropathic pain, I think it's a very important adjuvant to have. Next slide, please. So ketamine. So ketamine was used in the 1960s as a general anesthetic, and it has become quite in vogue again. It has many different uses, and it's used in multiple settings. It's used to treat cancer pain, it's used to treat neuropathic pain, it's used to treat post-surgical pain. It's a reversible antagonist at the NMDA receptor, which is responsible for wind-up. The NMDA receptor is found on peripheral afferent nociceptive neurons that synapse at the dorsal horn of the spinal cord and in the cortex, which might be part of the reason it contributes to decreased arousal and anti-nociceptive effects. It is also thought to exert its effects on mu opioid receptors, muscarinic receptors, monoaminergic receptors, and GABA receptors, and other receptors as well. It has been shown to have an opioid-sparing effect, but the impact on the actual pain score postoperatively is ambiguous. Ketamine is a pretty important medication in our arsenal for chronic and acute pain. In the chronic pain setting, we are able to offer ketamine infusions to patients who have a variety of chronic pain conditions, such as, cancer pain, neuropathic pain, fibromyalgia, complex regional pain syndrome. And then in the acute pain setting, I use it often as an adjunct along with propofol when I am inducing for anesthesia. We often use it for infusions in the perioperative period. And then even postoperatively, a lot of our patients end up on ketamine infusions. I think it's a useful adjunct in patients who have had large spinal surgeries, for patients who have a history of substance abuse disorders where you have a suspicion that perioperative pain control is going to be challenging. I think that ketamine is a great medication for that. And even for patients who are chronic pain patients who present for surgery or for a hospitalization who have been on opioids prior, I think ketamine provides a good amount of pain relief. Next slide, please. Ketamine does have side effects. For the most part, it's pretty well tolerated, but it can cause dizziness, dysphoria, headaches, dreams, and hallucinations. Other side effects include hepatotoxicity, uropathy, and an increase in ICP and intraocular pressure. As far as hepatotoxicity goes, often when we do ketamine in the chronic pain setting, we look at LFTs prior to administering it. Uropathy has been shown mostly in patients who use ketamine as an illicit substance. And then as far as long-term potential side effects, it is thought that it could cause an impaired cognition and impaired memory. And then the last medication I wanted to talk about was intravenous lidocaine. So intraoperatively, and as an anesthesiologist, it's thought that it decreases anesthetic requirements. I definitely often see patients with who get a little sedated after getting intravenous lidocaine. It decreases airway reactivity in smokers, and it's thought that it helps blunt the hemodynamic response to airway manipulation. It's often used post-operatively and intraoperatively as well as an infusion, and various dosing schemes are available. I've seen anywhere from 1.5 to 3 milligrams per kilogram per hour. It's shown to decrease your post-operative nausea and vomiting and your risk of ileus. There has been a small decrease in length of stay, and then a decrease in pain scores and opioid consumption. A lot of the analgesic benefits are strangely sort of surgery dependent. It's been shown to be very beneficial in patients who are receiving laparoscopic abdominal surgery, in patients who are receiving urological procedures, but then the studies have not shown that it's beneficial in patients who are receiving gynecological procedures. And the thought is that maybe the studies were not adequately powered. Next slide, please. As far as the mechanism of action, so when we think about using lidocaine for intravenous lidocaine to help with pain control, it's not the sodium and calcium channel blockade that we are actually interested in, but lidocaine helps cause a decrease in pro-inflammatory cytokines, including interleukin-6 and interleukin-8. It is also thought to inhibit NMDA receptors. And again, a lot of the benefits are seen in patients undergoing laparoscopic or open abdominal surgery. It is used occasionally in the chronic pain setting as well, 1.5 to 3 milligrams an hour for an hour, and we use it for patients who have chronic neuropathic pain. I've seen it used for fibromyalgia as well. Next slide, please. So side effects from intravenous lidocaine. Toxicity is rare, but it can present with tinnitus, perioral numbness, and cardiac arrhythmias. And anybody who is receiving this, you want to make sure they are properly being monitored. And then you could consider monitoring the blood levels in higher risk patients with renal or hepatic dysfunction. Because again, toxicity is rare, but it can be quite dangerous and even deadly. Next slide, please. So this is a list of my references, and that's the end of my talk. Hopefully you were able to learn some new medications or some new ways to use some of these older medications to help minimize opioid use for your acute patient. Thank you.
Thanks so much, Dr. Tarakia. So we'll get into a few questions from the audience before we close. First question, I think perhaps is for the both of you. Could a GABA vitamin be a sufficient for an alternative to gabapentin? Do either of you have thoughts on that?
I am not aware of any GABA vitamins. Sorry, I'm not up to speed on that.
I would say the same. I'm sorry.
Okay. No problem. Just wanted to ask. Okay. Another question, Dr. Khan-Arthur, you mentioned the X waiver and how some changes are coming, and that might require more inpatient physicians to be waivered. So do you have any thoughts on how to help physicians get more comfortable with prescribing buprenorphine or methadone, especially if addiction medicine is not their primary specialty?
Absolutely. I think anyone who manages pain should be a little dangerous at managing addiction as well, because it is, we always want to be able to manage the complications of the things that can arise while we're doing our procedures or treatments. So I highly recommend taking the actual waiver course. So actually taking it's only 8 hours. You take an 8-hour CME to actually learn the ins and outs of inductions and how buprenorphine works and that sort of thing. And there is tons out there at the National Institute of Health and NIDA that offer additional courses on using buprenorphine for not only addiction, but also addiction and chronic pain. And also along with that comes a lot of training and communication and how to talk to patients about this, which I think is probably the most important piece when broaching this subject. So things like SBIRT, screening brief intervention and referral to treatment training programs, highly recommended.
Absolutely. Dr. Tarakia, you have any thoughts?
I mean,
Okay.
I think it's important to have the certification, absolutely. And
Yeah,
I think it's an
absolutely.
important tool that we can provide to help battle this epidemic.
Great. Okay, so Dr. Tarakia, you said in your presentation about 40 to 70% of opioids prescribed perioperatively go unused. So do you know anything about what's happening at a policy level in the district or nationally to address this?
Again, I don't think there's anything happening at a policy level. I think awareness is probably the first step in education of, the anesthesiologist and our surgical colleagues. And again, I think that there are best practice recommendations. I mean, because I think of the databases they have in the state of Michigan, what they've done with this open project as far as education and sort of recommendations is incredible. So again, I think that it's the education of our colleagues and our patients is probably important. Looking at that open website or one of their papers yesterday, patients are prescribed 250 morphine equivalents for a typical laparoscopic cholecystectomy. And I think they end up using 30 morphine equivalents. So I think it ends up being like 6 tablets out of the 30 to 50 that they are prescribed, which leaves, over half of them available for diversion. The other thing that I think needs to be done is making drug take back more accessible, having more places that are willing, drug take back day is usually a day that's well advertised, but I think there need to be more resources to sort of drop these medications off without any sort of judgment, so that they're not just sitting there in your house. And when we prescribe medications, when I do prescribe chronic opioids in the chronic pain setting, keeping these medications locked away from kids, away from roommates, away from family members is an important part of our opioid agreement with patients.
Great. Okay, so another question for the both of you guys, kind of to your last point. What have you seen work in terms of changing norms and practices to help physicians use opioid alternatives first when managing pain? Other than, I know you mentioned education, but is there any other thoughts on maybe the structure within the hospital or a clinical setting?
I think having an acute pain service and a chronic pain service is a useful tool. And most of the times, whether it's a rheumatologist or an oncologist or a surgical colleague, they're more than happy to outsource the pain management to us. So we're going to offer adjuvants prior to escalating opioids for most patients. Lectures, lecturing my rheumatology colleagues, my oncology colleagues, my internal medicine colleagues on the options that are out there, I think are also useful. Institutionally, we also have a task force within the hospital and in the MFA, which helps sort of manage this as well.
I think one thing I'll say is Kaiser has invested heavily in our comprehensive chronic pain management program, which is essentially a chronic pain rehabilitation program. And this interdisciplinary approach to chronic pain, including, not only the pain specialist, but a pain pharmacist, pain psychologist, a nurse navigator, case management, that meet on a regular basis to help manage these patients, has been tremendous and really is at the core and the secret of our success in helping to reduce opioid prescribing and offer alternatives. And we also have complementary and alternative medicine. So these are things that are not traditionally considered lucrative in the fee-for-service world, but when you switch to a more value-based approach to managing chronic conditions, the investment will be returned to you in the future. So it's very important to invest in these interdisciplinary teams in managing chronic pain, especially, I believe.
Absolutely. So I think we have time for one more question. So in the prior session, the panel talked about the importance of family involvement in patient care. And you mentioned, Dr. Conarthur, that family and friends are often a main supplier of the daily dose of opioids. So can you discuss strategies to mitigate this risk and how important is education? I know we talked about education is important for physicians and clinicians, but how important is education for families of people that might be at risk for opioid use?
Yeah, absolutely. I think in approaching pain in general, you always want to take a biopsychosocial approach, right? That's the underpinning of what we do, especially in chronic pain management. And that psychosocial aspect includes the family and the community supports that are available to them. One technique I use is whenever I'm prescribing opioids, I always have a discussion about naloxone, Narcan, with family members. And I make it a point to say, I need to speak to a family member to discuss these risks and why this additional medication is necessary. And sometimes that leads to very, very interesting conversations and insights about the patient's function and about how they're actually using opiates at home and things like that. So the more you can loop in other observers, people who actually observe the patient's function, the more information you can gain and help to devise your plan as you proceed.
Dr. Taraki, I don't know if you have any thoughts. I don't want to leave you out.
Sure. I mean, I think this is a team-based approach, and I think the more people that you can recruit on your team, the better off you're going to be. And it's oftentimes the family members who are seeing the patient in pain. So when they come to clinic with you, all they know is that at home, this patient is on the couch upset because of the pain, or unable to take care of the grandkids, or unable to help them in the kitchen or do the things they like. And they see that, but then they don't understand oftentimes the side effects that we're trying to avoid. We, as chronic pain practitioners and acute pain practitioners, don't want our patients to be in pain, but we want to be able to sort of make sure that what we do now isn't going to be a problem in a year, 2 years, 5 years, 10 years. So I think having them available for the discussion from the beginning, going over the risks and benefits of being on opioids or why we're trying to minimize them is as important as having the patient on board.
Absolutely. Well, I think we reached the end. Just thank you so much, Dr. Conarthur and Dr. Tarakia, for sharing your expertise from a more clinical perspective on both opioids and chronic pain management. I think it was really insightful for the clinicians and the pharmacists on the phone. So thank you for participating today.